Thank you. Good afternoon. Neuromodulation offers really the potential to disrupt and cure a number of the most devastating diseases in human condition. We heard today about epilepsy, and it doesn't take much to see that some of the devices that we have FDA approved right now in humans, like the one I'm showing here, are less than ideal. What you see there is a huge battery that needs to be replaced every 2 to 3 years. That's a brain surgery to replace a battery every 3 years. Wires passing through the skin, bone that can migrate, can infect, can fail, can bleed. There's got to be a better way. What if I told you there was? Introducing the first completely wireless, battery-free brain or spine implant that can stimulate and record and takes advantage of a unique surgical technique pioneered by our group, in which we place this in an off-the-shelf FDA-approved dural graft. What is the dural graft? Whenever we do brain or spine surgery, to get to the nervous tissue, you really have to go through multiple layers, as I'm showing here on the left. You go through skin, bone, and then there's this final layer of thin membrane we call dura before you get to the nervous tissue. Because our implant is so thin and so flexible, we can actually pack it inside one of these off-the-shelf materials and use it for any already occurring surgery. Our team really combines the unique expertise of Mayo Clinic and Arizona State University in partnership with our industry collaboration, so we can bring this to patients. We've done our homework. As you can see here, over the last 5 years, we've developed this, and we have more than 5 US patents. One provisional we just filed today. We have more than 10 peer-reviewed publications, animal studies. We've got funding, and we're in the process of doing large animal studies to bring this to patients. This is a race to be first to market in a game where the first one wins it all. Epilepsy alone is $20 to $50 billion of addressable market. And I haven't even started talking about stroke, trauma, tumor, pain. So who wants to join me in this journey and take a bite of what I like to call the first pacemaker for the brain? Thank you, and I'll take any questions.
Thank you very much for the presentation. The first question I have for you is, the field of neurology and neurological disorders is very large, but you mentioned that you see this as a race to be first in creating the first brain pacemaker. Could you elaborate on that, please?
Correct. So our technology in and on itself, so for instance, the ability to have a wireless device in and on itself is not completely new. There's multiple people racing to develop, for instance, scalp EEGs. There are ultra long duration, 12 months, 18 months. The ability to be battery-free itself is also not necessarily novel. When you combine what we're proposing with the surgical technique we're proposing, then it becomes something truly unique. Now, once the idea gets out, as you know, it really becomes a race to be able to get to market, so you can establish that position and then construct a mode, which we've tried to do with the number of patents we've been able to do. Absolutely.
With no batteries in the brain, it's going to require something on the outside, right? And so have you done work with patients about acceptability and the issues of non-compliance with that?
Absolutely. So that's a great question. So the way this works, we use radio frequency harvesting. So there's an external antenna, which we've also patented. So all the patients will have to wear is almost like a cochlear implant where you place the antenna with a battery that can be replaced every day or every 2 days. So that really solves 2 issues. One, we don't need to have the battery and the bulk electronics inside. And also you can use much cheaper batteries because this becomes almost like a wearable. You can just recharge every day.
There's at least one other company out there that has already done successful implants of endovascularly placed, electrodes. How do you see that kind of competition between, minimally invasive endovascular approach versus a surgical approach?
Absolutely. Thank you for the question. So our case study was really epilepsy, where being next to the cortical tissue becomes key. And that becomes in and on itself a unique application where I don't think we would have overlap. When I mentioned, for instance, stroke or trauma, we were mostly targeting neuroplasticity by stimulation, where there has been a lot of interest over the years and more so lately. But really the ability to do this safely long-term or lifelong has really escaped technology that we had at the moment, but we think with this we could be there.
You said that in the description that you've tested this out on mice, which suggests that it's extraordinarily small and would be a minimal surgical insertion. Will it be the same size and the same effectiveness?
Thank you. That's a great question. So To do it in mice, I actually think in terms of technical aspects is harder than humans in some aspects, as you mentioned, because it is extremely small, but we use microfabrication techniques to be able to do this in mice. We are also doing now porcine studies with a larger, almost like human-ready design with larger antennas, which we can tailor make for the indication. So for instance, if we know the foci for epilepsy is this precise location, maybe you don't need so many electrodes or such a big device. But if you have someone more with a bigger focus, then you can really do that. And we have the ability to do so.
Elon Musk and his Neuralink, right? And he's saying first implants in a year.
Well, we'll see.